Welcome to This Week in Health IT, where we amplify great thinking to propel healthcare forward. My name is Bill Russell, Healthcare CIO, coach, and creator of This Week in Health IT, a set of podcasts, videos, and collaboration events dedicated to developing the next generation of health leaders. This episode and every episode since we started the COVID-19 series has been sponsored by Sirius Healthcare. Now we're exiting the series, and Sirius has stepped up to be the weekly sponsor for the show through the end of the year. Special thanks to Sirius for supporting the show's efforts during the crisis and beyond. Don't forget, we've gone to 3 shows a week. Tuesday, we cover the news, Tuesday Newsday, and we have interviews with industry influencers on Wednesday and Friday. I am actually going to take a week off next week. However, we have a special treat for you in that Drexta Ford, frequent guest on the show, will be in on Tuesday to cover the news. So we are going to have a Tuesday Newsday episode next week, and I'm looking forward to that. I will consume it as a listener just like you. I want to thank everyone for your support of the show. We've eclipsed 100,000 podcast downloads through the first 6 months of the year, and that is what continues to make this the fastest growing podcast in the health IT space. Thanks for sharing it with your peers. To make it easier for you to share with your peers, we've launched Clip Notes, and I am really excited about your response to Clip Notes. We've gotten a bunch of emails from you, and a ton of you have signed up, and I really appreciate that. What is Clip Notes? Clip Notes is, quite frankly, a way for you to get a single email that condenses the entire show for you. And it gives you a 1-paragraph summary, gives you bullet points with timestamps so that you can go to your favorite parts. And it has 1 to 4 clips from each show, which has highlights from the show that make it easy for you to share with your peers, to share with your staff, to share with other people within your organization so that you can keep them on the cutting edge of what's going on. To subscribe, there's two easy ways to do that. You could hit the website, hit any show, and subscribe to Clip Notes is right there on the page and in the right side. You can also just send an email to clipnotes@thisweekinhealthit.com, CLIPNOTES at thisweekinhealthit.com, and that will kick off a workflow that gets you a link in an email that you can click on and subscribe to Clip Notes. I am really excited for today's show. We have a special guest, Charles Boicey, who I've had on the show before. Charles is one of my favorite CTOs in the industry. He has a clinical background. He is a technology genius. And we do a little role playing here where I act as a CIO, he acts as a CTO, and we go through all the things that we are facing as a health system today, from 21st century cures to the HHS and ONC changes to cloud to cost reduction, you name it. We try to tackle it from a CIO, CTO conversation in my office standpoint. I hope you enjoy. All right. Today we are welcoming back Charles Boicey, the CTO for ClearSense. Charles, welcome back to the show.
Hey, Bill. Good to see you.
You know, it's been a while since I've had you on the show. We've had a lot of conversations, especially through the pandemic. You've been a wise counsel for me, helping me to understand some of the things that are going on. But I have a special show lined up for you. As you know, I've tried to hire you on several occasions, and I've been left at the altar. I tried to hire you when you left UCI, but you decided to go to Stony Brook. And then when you left Stony Brook, once again, I was left at the altar, and you went to be the CTO of ClearSense. And I think that speaks for, at least to my respect for you, as one of the best healthcare CTOs that I've ever come across. So today's show, we're going to role play. For the first time I've hired you. I actually won the competition, and what we're going to do is we're going to role play with me as the CIO, you as a CTO, and we're just going to run through a bunch of things that are going on in healthcare right now and see how we would, come up with solutions for them. Are you ready for this?
Hey, Bill, you know what they say, paybacks are you know what. So I guess I'm going to get my due. So let's go.
All right, we'll see. All right, so we're sitting in my office. Here are some of the challenges that I'm currently looking at as the CIO and the health system. So HHS, CDC reporting, this Twitter went crazy on this. The Trump administration just announced that you have to start sending your information over to HHS instead of the CDC. You're my CTO. So how hard is it going to be for us to make this happen?
Well, Bill, really who the hell cares whether it goes to the CDC or HHS? And if you look at how many data elements are involved, that's a small effort as well. So, outside of, a different file format, let's just, redirect to a different, secure file transport. as far as I'm concerned, we'll do the same ETL. We'll produce basically the same file. We'll send it somewhere else, and hopefully they do a little bit better job with it.
Right. Well, all right. So let me get more specific. So I'm actually looking at the HHS document. They have 32 data elements. So hospital information, which is pretty easy stuff, right? A lot of this stuff is just ADT feeds and stuff right out of our teletracking. So hospital information, pretty straightforward. Number of hospital beds, inpatient hospital beds, occupancy amongst those inpatient beds, ICU bed occupancy, total ventilators in use. So this kind of information, is this readily available to us, or are we going to have to do something special to pull it all together?
No, it's readily available, Bill, but let's introduce what healthcare usually introduces to these types of things.
Complexity.
What time of day is that? Is that midnight? Is it after midnight? Is it 6 a.m.? Is it 8 p.m.? And this is kind of the damage that we kind of do to ourselves, right? So yes, all those data elements are available, and it's just a matter of did everybody get together nationally and decide this is going to be at at 12 o'clock midnight kind of a thing, or is it 6 a.m.? So I think those kinds of things we kind of spin on ourselves, but from a data perspective, we should be doing this.
Well, Charles,
we should be doing this anyhow, Bill, because we really need to know from our own perspective, when we're projecting out PPE and so forth, what capacity, all of that. This should be part of our DNA right now. If it isn't, I'd be super surprised.
Well, that's why we hired you as a CTO, so we can get this to be part of our DNA. But let me ask you this: that question is not an innocuous one, because we do spin on some things, definitions of things. So does it matter what time we take this inventory, as long as it's consistent on a daily basis?
No, I don't think so. But again, I just brought that point up to show how silly we can be at times. But no.
So are you concerned at all? I mean, this is not a CTO question, but are you concerned at all that, the CDC is readily available to researchers and those, that database is open and the HHS database may not be open? Is that a concern for you at all?
Yeah, that's a concern. It's been a concern for most. Amy had put out, a letter, if you will, the last couple of days. So it's a concern for many. So here's the concern, Bill. What is HHS going to do with it differently than the CDC did? Is it, a benefit? Will the CDC get access to that data? I have no idea. It's interesting. What did they do wrong? Those types of questions that I really don't have the answer to. But, from a purposes of reporting, does it really matter where it goes? It all depends on what the use is going to be with that data.
So for our purposes, redirecting it is really a pretty basic thing.
Yeah, technically for us, no deal, no issue and whatnot. But for the country, healthcare at large, what is the difference between the CDC not having access to that, and we don't know that answer, versus Health and Human Services?
Yeah. All right. Well, let's move on to some other topics. We've got a tight schedule, and all right. So we're coming through the pandemic. We had a significant cut in our revenue. I'm being asked to do more with less as a CIO. I'm glad we're playing this game of, I don't get to ask these questions of the CIOs I have on, but let's assume our health system, I'm looking at a 10 to 15% cut, whereas I normally get a 3 to 5% increase every year. I don't have a lot of variable costs. So, outside of cutting people, which is one of the things that always sort of comes up when you're looking at a cut of this size, what are some other things we can do to do more with less? Data center operations, outsourcing, overseas. Are there other creative things I should be thinking about?
Sure. So I think the first campaign is a smile and dial campaign to your vendors. What can you do? Hey, look, we've been in this for a long time. I'm going to need some concessions. And you may or may not get it, going forward. Even at the data center level, I'm going to need to, for the next 6 months, decrease, my spend there by X. And you can tack it on at the end of that contract year, which may be 2 or 3 years out. So doing things like that is essential. Bill, how many systems do you have running in your organization right now that you have on in lights on only, where you're paying maintenance on the software? You're paying for the electricity. You're paying for the footprint. What systems could you archive and turn off with giving them access and so forth that they could then, realize, that benefit. That could be several $100,000, annually. From a, personnel perspective, what could you, potentially, outsource? How much of the work that your team is doing that, could be, potentially, done, offshore? And, when you talk about offshore, yes, you have skilled work. Yes, you have a lower cost, but is the work that they're doing and is your organization at a point where, somebody, external can, access your data if that's the kind of, development work that they're going to be doing.
I want to come back to offshore outsourcing because you've done a fair amount of that in healthcare that has there's some interesting challenges with that. But first I want to come back to something you said earlier, which is shutting off those systems that are just sitting there with lights on. And, this is one of the things that you and I actually did work on. You were with a vendor and I was a CIO. And when we were moving to the cloud, we inventoried all of our systems and found out that a good 10% of them were not being used by anyone. I mean, no one in the organization was using them anymore. And I think, people think, well, application rationalization, that takes a long time and you got to think through and you got to do all these things. But at the end of the day, there's low-hanging fruit at almost every organization of systems that are just sitting there doing nothing. Has that been your experience?
Yeah, absolutely. And, you talk about, and many times, if the, from the vendor situation, it hasn't been centralized, you could have various departments using various applications and, believe it or not, paying, various rates for those, departmental applications. That actually still exists. So both, Bill. It's very much like, back in the day when, orthopedic surgeons would be dealing with a vendor and each surgeon would be charged a different price for the same, implant, if you will. So yeah, there's a bunch we can do from just the software that we're using, whether it be, renegotiating contracts, finding out, if departments are, doing things on their own. And then, yes, what's out there that isn't being used that we can, turn off and just be done with it.
Well, I'm a huge proponent in planning ahead. So I hate when you get asked, hey, you need to cut 15% this year if you haven't been planning for it. And so almost every year I go to my team and say, hey, can we figure out how we're going to cut 5% next year and give them a full 12 months to think about those things? So in that vein, talk to me about data center operations, because one of the things that's always shocked me when I talk to you is how re-architecting a platform gives you the ability to really cut down on the number of people that needs to support a significantly large set of servers and storage and equipment. So, what are some things we can do in data center ops?
Sure. So it's a combination of basically, hardware, as well as a combination, a different skill set, if you will, as well as monitoring everything. And I'll kind of get into that in a bit. So, we unfortunately got to get into the tech bill. There's no way I'm going to be able to get away from that.
I welcome it. Let's do it.
So, bringing on what's called a hyperconverged infrastructure. And that is, the ability to actually, from a storage perspective and from a compute perspective, actually use that which is needed. And from a storage perspective in particular, to be able to scale out as needed with low-cost commodity equipment, even the introduction of, low-cost, SSDs and so forth. So you're really distributing from a storage perspective, and you're using what you need, no more than that, but you're architected as such that you kind of keep yourself future-proof and that you can expand upon that. And even the introduction on the compute side to be able to scale, on CPUs, on RAM. And if you're now into a data science rich environment, GPU introduction, that's at the base bare metal level. And if you think of hyperconverged on top of that, we're now, I'm not going to mention vendor names, but now we have the ability to, in the same environment, bare metal servers, virtual machines, which everybody's familiar with, as we move more into a containerized environment, and our client and our vendors are moving that way, and then even further advanced for a serverless environment. So this sets us up for two potentials. One is I talked about, future proofing as emerging technologies come in. This is the environment for them. And let's go, if you want to go into it now, we can. You mentioned earlier, this sets us up for a hybrid for potential of a cloud environment. And if you want to go there, we'll go there. But this is really setting you up for that eventuality.
So everything is software based. It's software defined. We can actually write code. We can actually have it not be written code, that the amount of volume or the load on the server will kick in additional processes and those kind of things, if the software is written to take advantage of those kind of things.
Yeah, that's correct. So workloads in a containerized environment, as they increase, multiple containers are spun up. You're exactly right. It gets away from how we used to do things where, okay, we reach capacity. Now we got to throw that out and get a bigger box, right? And then we reach capacity. Now we got to get a bigger box. It prevents that, every 3 years from having to just rip and replace.
Yeah. It's, what do you say to I'm going to get a lot of pushback from our technical team. I just hired you. That technical team is going to say, look, we have too much legacy. And if you're running legacy, you got to run it on old architecture. Is that the case?
No, it's not the case. And it's very interesting that you said that. There is a lot of remedies within that hyperconverged infrastructure where we can actually bring that into that environment. Is it a cakewalk? Absolutely not. But it's something that can be done. It's essential.
All right, I'm going to come back to cloud. Let's talk a little bit about overseas and
Sure.
Working with overseas resources. So, you have some experience there. I have some experience there. Let's start with, what are some of the considerations when health systems outsource overseas? Just flat out that question. What are some considerations we need to talk about?
Sure. So you have to have, some representation in the States. You have to, really understand, what that workforce looks like. What were the universities that workforce came out of, which is essential. And you can outsource to Ukraine. You can outsource to, Spain, Dominican Republic. My outsourcing, country of choice, as you know, is India. And it's not, as most people think, because of the cost perspective, and there absolutely is cost savings. It's the fact that it is very, very difficult to get into those top-notch schools. It takes pretty much, from a very young age, to get into those. That is your goal. You've gotten into those schools, and as a result, you're a hot commodity. And those are the folks that I go after. I know those universities. I recruit from those universities. And as a result, I have the best of the best, from a architecture perspective all the way down to hands-on coding.
So it sounds like you're pretty hands-on. I mean, you are actually recruiting these people. Do you spend time in India as well?
Well, I used to, up until what's going on now, where I go at least 3 times a year, if not 4. But that is a group that's, that those teams. And again, Bill, I'll go back. I've had a team since 2007. So, this has been, 13 years for me with, excellent, results and success. You've got, we're on Zoom right now. So, you've got a whole bunch of technology that assists in that. From a monitoring perspective, cost savings perspective, 24/7 monitoring, I have, done in India. Development, absolutely. Depending on the organization, there may be some restrictions on what they're able to, be involved with as far as, data access and whatnot, but that can be mitigated as well with de-identified, obfuscated data sets and so forth.
Yeah, it's interesting because a lot of CIOs, like I was challenged with follow the sun support, essentially 7x24 coverage, because the hospital never closes. And so you could either try to do that in the States, which is extremely hard, or you could literally get 7x24 with just the States and India for the most part. When we're going to bed,
it's not somebody looking at, Zabbix or Grafana or some of these monitoring the software. It's actually people in there, doing maintenance as well. So if you think about what your networking team, what your engineering team are doing, during the 40 hours that they're working, and now you can extend that to additional 40 in those off hours, and your systems are pretty much maintained. And kind of going back to that, bringing in that, hyperconverged and so forth and, software defined networks and the rest of it. Yes, it's a higher skill set, but it takes less people to maintain that as long as they're at that skill set level.
Yeah. I want to be clear. We're not recommending that organizations do this, although we have both done it, which I think speaks to.
Oh yeah. We're just talking about it. Yeah, I get it.
Yeah. 21st century cures. Well, let's go to cloud. Then we'll come back to 21st century cures. Cloud and DevOps. Let's just start with the flat out question. What is a cloud strategy?
Yeah. What is a cloud strategy? So I'll give you my definition of it. It's not a choice. And what I mean by that is you have your own on-prem cloud. You could have a private cloud located somewhere else, in a co-located environment. You've got Google, you've got Azure, you've got AWS. The whole ecosystem is a cloud. Does that make sense to you? You're not making a choice. You're in a cloud environment now, whether you know it or not. And because of, how we are doing things now from an API perspective, if I want to run a workload in Google BigQuery, then I will run a workload in Google BigQuery. If from a storage perspective, I want to store all my data on-prem, great. If there's some tools within AWS that I want to bring on, and work in my environment, I can do that as well. So I can move workloads around as I need. Is it all or none? No, it absolutely isn't. And I think this is something that we'll see, evolve as time evolves, where I'm not making a decision to shut down my data center and move to, let's say, AWS. I'm going to do everything in AWS. No, there's interconnectivity between all those cloud vendors, and I've used them, and they're fast. So we are in a cloud environment. And how are we going to best utilize it?
And from a CIO perspective, what I would say a cloud strategy is, it is you getting the most agility and efficiency for your organization, providing the most capabilities to your organization, right? So, the reason we talk about cloud at all is because cloud gives you the agility, the efficiency, and the capabilities, right? We can spin things up overnight that we used to have to plan 6 months for and order servers and put them in your data center. And so the cloud as a model for how to build out your infrastructure in order to serve the capabilities and the applications, even smaller, the services that you're going to be providing, it is now table stakes. And so when I talk about a cloud strategy, I'm talking about, how are you thinking about public, private, hybrid cloud? How are you thinking about, cloud apps and how do they integrate? How are you doing in identity and access management as the perimeter around your cloud strategy? It's you have to be able to answer those questions as a CIO and a CTO for your organization. Because if you don't answer them, then it's just it's just another one of those hype words that gets used over and over. Yeah, we're in the cloud. We use Workday, and you're like, okay, that is a cloud application, but what is your cloud strategy? Anyway, you and I have gone round and round.
Yeah, if you think about it, Bill, from an R&D perspective, you're absolutely right. I need to do this. And I will say from a data science perspective and from a research perspective, I can spin up an environment, do the work that I need to do, and then collapse it. And then I'm, on my way. And I can deploy that model within my environment. If I have some heavy, heavy workload that's, going to use heavy, GPU just to, do the, build out the model, then, I can do that in another environment and then deploy in my environment.
Well, it's, so you and I have actually talked about this, and I've consulted with some organizations on this that are saying, hey, healthcare in an AWS cloud or in an Azure cloud, how do we ensure HIPAA? How do we ensure the security levels and the things that were normally identified as required for HIPAA? Like, some people think that HIPAA requires us to point to a server and say the data is on that server, but in a cloud environment, we don't do that really much anymore. So how do we ensure that level of compliance to those security frameworks?
Sure. So if we're going outside of our private cloud, then we have to assure that high trust, SOC 2, there's a couple ISOs thrown in there, not just, HIPAA. So, if you're, whether, it doesn't matter what the environment is, you have to be able to not only, build that out or have the insurances and get that, get those certs and whatnot, those compliances. And then you have to be able to demonstrate it and, ongoing because it is healthcare data.
Right. And, one of the things you put me on too is I used to get all worked up that I'm going to have to do all those things, but there are companies out there that build wrappers just for healthcare to make them work. All right, let's hit 21st century cures. That is right around the corner. We have a data blocking challenge that we have to overcome. What are some of the ways that we can make sure that we're ready to share the entire patient record digitally with the patient?
Well, you would have to ask me that one, didn't you?
Is this a hard one to answer?
This is well, think about it, Bill. This is what we've been trying to do since, from day one. We have all kinds of standards, and, that really is the issue. We have all kinds of standards, right? We have some definitions. We've got to adhere to them. We have some successes with, health information exchanges. Some states have done very well. Others have done, very poorly. It's out there. We've got to do it. How much should we rely on our EHR vendors? I don't know. And I'm probably giving you some really crappy answers. And, I don't mean to, but it does have to be more of an organized, effort, if you will, and not a organization by organization trying to, kind of figure this out.
Right. So a lot of us are going to rely on our EHR provider to meet this needs. But at the end of the day, here's I think what we're required to do is if somebody requests access to their patient record digitally, we have to provide it. Now, typically what that's going to look like is somebody's going to go out and write an app. They're going to sign up people, and those people are going to make requests through that app to our health system for their record so that they can provide their service to that patient. And we're going to see probably a proliferation of these digital health type companies come to the fore, and they're going to hire clinicians who are going to help us to figure out care plans, or you fill in the blank. I'm not really sure how that's going to happen. I could even see the insurance companies making these requests as well. So we have a lot of mechanisms to share this, right? I mean, all I have to do is put this through a standard Fire server and put it out there, but not all the data elements are really built out in Fire yet, are they?
No, they're not. And, are all of the ontologies properly applied, and is that something that we need to, be concerned with? And, the accuracy, the completeness, those are, all questions that, we've got to answer, and we don't really have, all that much time to do it. Right now somebody comes and asks us for, their record, we're able to accommodate that. But, from a longitudinal perspective, and, thinking of other entities that are involved here, we've got a considerable amount of work to do. If I go to several different organizations, that, compounds. How do I personally get a longitudinal record, through, having visited several different healthcare organizations.
So you're now counseling me as the CIO. Are you saying I should get behind efforts that should ask for a delay? Are you saying that I need to stand up a team that really delves into this? Which direction should I be going, or both?
Yeah, I'm saying that, Bill, from your HR perspective, you better have your ear to the, what the vendor is doing, and, really pay close attention, and, what's the heads up from your vendor of what you're going to have to do versus, what they're going to be able to do to, help you meet those, requirements. And, hopefully it isn't a, complete, download of, all the data elements, and then you having to have the onus of, processing that, and then at the end product is the product that, gets distributed, because that's a considerable amount of work. And hopefully they're able to, do that within that environment.
Now, Charles, you have been with companies as CTO of companies that have consumed whole data sets on the patient. I mean, how ugly is that? How hard is that? If you and I were going to go out and start a new company and we were going to write a patient app and they said, look, we're just going to give you a raw dump of the file, could we make sense of it?
Yeah, we can make sense of from a an EHR dump, if you will, taking that and running it through a pipeline. Some of the obstacles that we're going to run into are what I call ontological right sizing. So assurance that the various ontologies are correctly applied, assurance that that is actually the patient that it's stated. So the whole EMPI needs to be part of that processing, if you will. And then from an output, the assurance that the output is actually, formatted in the form that is expected for ingestion into the next application, or, is suitable for, distribution at that point.
So are you coaching me to ask for a delay? Should I get on that bandwagon of people who are saying, look, we need more time?
I'm not one for, asking for more time. I'm one for, getting to work and, start working on, what's going to be required. And that's just, beating up everybody and their brother to get as much information, as you can to best position yourself.
Yeah. And that's the problem with that crowd, to be honest with you. And if somebody's in that crowd on that's listening to the show, I apologize. But, the problem with that crowd is it's hard to distinguish between the people who are saying, look, we've looked at this, we need a little bit more time, but we're going to make progress and we're going to get there. And the people who say we need more time, and then when you get to the end of that block of time, they're saying, hey, we need more time. And they're going to keep doing that for the next decade, right? So there's those clumps of people in that. And that's why I, like you, struggle to get in that crowd of saying, hey, give me some more time. I want to make as much progress as we possibly can, given the time that we do have, see what we can actually do to be compliant. That's sort of how I think about it.
Yeah, you've got that whole, thing, that cloud hanging over all of this, that competitive advantage, cloud. If data is easily exchangeable and so forth, does from an organizational perspective, does that make me less competitive? That the folks down the street, may, have some insights into, how I handle my operations, clinically, financial, and operational. And then if you look at it from a national perspective, what organizations are doing, better than others. So I think there's a lot of worry there. And even on the vendor side.
Are you familiar with US CDI at this point?
No, I am not.
Okay. All right. We'll talk about that later. But I think that provides some of the framework that we need to make sense of the data. All right. So you're my CTO. Give me an idea of how you think of build versus buy. Do you favor one versus the other?
It all depends on the skill set that you have incumbent and understanding. So let's say I want to build out I'm going to build out a big data platform. Why are you going to build out that big data platform? Understanding the why of it, really understanding what you want to do and, why do you need to do it versus, working with a vendor to do that. And I'll tell you where it gets really complicated, Bill. And it has to do with data science as well as the skill level that it takes to build these systems out and build them out properly. Many, many times, Bill, if you don't know the skill set that's required, you're going to make some mistakes in the hiring. Even if you use somebody to bring people in, you're still going to make those mistakes. And those mistakes can be costly from a time perspective. So if I bring in an architect, I bring in an engineer, I bring in a team that's going to not only architect out, but also do the purchasing, the rack and stack, and then the build out. And somewhere during that process, I realized that I probably brought the wrong people in. Now I've architected a solution that probably isn't the best. And now I'm in a bit of a bind. And I see it the same with bringing in, data scientists as well, where organizations really don't know, what type of individual, what they're actually going to be doing. It just sounds really good to let's bring one in. And they bring one in and they find out, later down the road that they really brought in, the wrong individual. So I think from the perspective of personnel, I think there's, some considerations. If you have the proper team, I think you're in a good spot. If you don't, probably not. And the most important part, Bill, that I always talk about is we learned from COVID that the need for data and what we have to do with data is increasing exponentially, and that technology needs to follow that same type of exponential growth. And it's a time perspective. So if I'm going to build something out, I'm going to build a team. 6 months. 8 months, a couple of team members weren't quite what I thought. Now I'm into 8 to 9 months. I still don't have anything. I got the architecture. Now I've got all the equipment. I've done the racking and stacking. We're at the end of year one. Now I'm starting to, build all this out. And now I'm getting into the 6th month. I still don't have any data. So we're getting into 18 months and I'm really not getting a whole lot of use. And, I'm probably going to realize, use in 18 to 24 months. And oh my gosh, guess what? We didn't do so well on our revenue targets and we just became an M&A target and now we've been acquired. And, what do you know? That organization already had a data platform and, now we're in trouble. So yeah, so the build versus buy, if you can do it if you can do it quick and you've got the right people, by all means. If you need to get going, I would really consider the buy.
This is, it's interesting. You and I think the same around these things but we also understand the value of teams. So we build out the teams. And so when I go from organization to organization, I still have teams that I can call on that can do different things like develop applications, develop websites. You and your team can stand up a big data science team almost overnight. And you keep those and you build those out so that you have that value, that you know that whatever you do next, you can stand it up very quickly.
Yeah, you just go on to the next challenge, right?
Yep. And you still have the tool set with you. Last thing, talk to me about Digital Front Door. Build your own, utilize components of the EHR provider, utilize best of digital kind of approach. How are you thinking about a Digital Front Door?
Bill, I want to hear your definition of Digital Front Door first.
Digital Front Door is how we digitally engage with our patient community, actually beyond the patient community, how we interact with our community to deliver health, right? So it's everything from easing the friction to interacting with our health system. So, digital appointments, digital scheduling, digital visits, to coalescing the information around all the devices that we put in the home. So the patient-centered medical home, which has now evolved into really a digital care platform that's delivered out of the home, but we coalesce all that information into that. It becomes the gateway, if you will, for more touch points. We are engaged with that patient, with our community on an ongoing basis to be their resource for health at all times.
And Bill, as your CTO, I needed that definition first, right?
Yeah.
Okay. So that's a big one. First of all, I say, let's go look at organizations that outside of healthcare that have done this really well. So who's done this type of thing really well, especially in the world of COVID, who needed people in their doors, to keep the revenue up and, keep, going. You talk about Uberization is a word. What can we learn? And we should learn from, those in retail, logistics, and how they've engaged and kept people engaged from a front door perspective. So it's great to have a bot on your website, but what's the bot actually doing? Is the bot bringing somebody to a destination? So if I log in and I'm looking to make an appointment, can that bot bring me through all the way to an endpoint? And did you, by the way, have self-scheduling? Did you have all those components in place? So what I'm getting at is you really have to think this thing from end to end and not miss any of those component pieces. It's really critical that we all have call centers now. Not sure why healthcare is in the call center business, but we are in the call center business since we made that decision. Let's take care of it. We have, bots that can help us through that for call deflection. We have intelligent agents that can handle a lot of those calls. Are we using them in healthcare? Absolutely not. We also have artificial intelligence that can monitor those calls and score those calls so that we, again, bring the level of, the level of, customer care, to its highest. We're not utilizing any of that stuff. So first of all, I say when they land on our site, let's get them to where they need. Secondary to that, from a, device in the home perspective, we did pretty damn good over the last several months with doing telemedicine in all kinds of weird ass, crazy kinds of ways, utilizing Zoom, utilizing, all of these different, tech. We responded pretty good with that. So, expanding that, professionalizing that a little bit, a little bit more. And then for monitoring and so forth from the home, again, it has to be purposeful. I, as a clinician, do not want to log into my EMR and see, 1,500 blood sugars from, my 1,500 diabetic patients. That needs to be meaningful. My team needs to know that, one of my patients is a little wonky in their blood sugar, and I need to, take care of that. Or from a blood pressure perspective, I don't want to see all that stuff, but I need to be aware. So we need to make it really smart, and we need to make it simple for the patient population. Plugging stuff in and getting connectivity and all that kind of stuff, really has to be an excellent experience. Otherwise, we've got a problem. And the last thing I'm going to say about this call center business is, when you get somebody on the line, you better know who they are, where they are, where in proximity they need to be, for whatever the provider, and you better get them to that location and not be sending them all over the place, over, several miles and whatnot. And one of the things that I've seen that just is extremely frustrating is I'll do a telemedicine visit, but when all this is over, I'm going to be followed up. Oh, I'm not going to see that person because they're, 30 miles away from me. Why didn't you connect me with somebody that I can, follow up with after this is all over? So we got to think about it from really from a marketing retail. Look what everybody else is doing and bring that into healthcare. And from a call center perspective, there is a lot of work we need to do.
You just gave away all of our secrets. When you and I get together, we like to, the one question we bat around is, where do you think the best entrepreneurial idea is? And whenever we focus on healthcare, I think people will be shocked some of the areas we come up with, because, we have fairly deep experience in a lot of different areas, but you and I agree that the one area that if you and I ever got together, we could revolutionize in healthcare, it is the call center across the board.
Oh,
it doesn't matter what they're doing. We can change it completely.
And the other one is, why the heck are we spending so much time and energy on recovery, on bill collection? There's far better ways to take care of that. Why are we doing that?
Yeah. But even if we were doing it, we're not using the right analytics. We're not using the right tools. We're not using the right.
Yeah. Who's likely to pay? Data science project on, who's likely to pay. Data science project on, what's the best, methodology for delivering care. I mean, there's a lot of stuff.
All right. You can't give away all of our secrets here. Charles, thanks. I really appreciate you coming on the show. I think there's a fair amount of sound bites and things for people to take away. And I'm already looking forward to our next conversation. Cool. I really appreciate being here. And Bill, welcome to Florida. Thanks. It's rained all day today. So thanks for the welcome. That's all for this week. Special thanks to our sponsors, VMware, Starbridge Advisors, Galen Healthcare, HealthLyrics, Sirius Healthcare, and ProTalent Advisors for choosing to invest in developing the next generation of health leaders. If you want to support the fastest growing podcast in the health IT space, most of you can say this now without me even finishing it. The best way to do that is to share it with a peer. Stop right now, send an email, tell somebody, hey, this is a great show. I'm getting a lot out of it. You're going to want to check out these interviews and conversations. The second best way you can do it is you can subscribe to our YouTube channel. We're putting an awful lot of new stuff out there, and it's exciting. The live show will only be available on the YouTube channel. It will not be dropped into the podcast channel. Some of you asked me to drop it in last time, but my team here internally wants me to stay focused on the strategy, and that is to have content that is specific to YouTube and to start to diversify our channels, if you will. So some of our content will only be available on YouTube. So get over there and subscribe so you know when it's available. Thanks for listening. That's all for now.